Welcome to our webinar From FLAIR to Static. Now that the static trial is about to open, we've invited Professor Pete Hellman and Dr. Tal Munir to discuss what patients might expect and how you can get involved. Professor Pete Hellman leads the experimental hematology section at the University of Leeds School of Medicine, and he's been involved in the FLAIR trial since its inception. He's now handing over as Chief Inspector on the static trial to Dr. Tal Munir, but will continue to be involved. Dr. Munir is consultant hematologist at Leeds NHS Trust, where he specialises in chronic lymphocytic leukemia. He's been working on the development of the trial concept and design of static, as well as on FLAIR, and he's now leading the CLL service in Leeds. I'm Hilary Lindsay. I'm a trustee of CLL Support, and I and my colleague Lelia Dooley, who is joining us from somewhere between here and Australia, so if she disappears, you know why. We are both the patient and public involvement and engagement representatives on the static trial. So we're particularly pleased that this webinar is happening. So with that, it gives me great pleasure to hand over to Dr. Tal Munir.
Hello, many thanks for your very clear introduction, and many thanks for having me here. It's my pleasure to be here and talking to you about this static study, which obviously has taken some time to come up because of multiple reasons, and we can talk about that later. But I think it's important to say that I'm here because essentially all of you who participated in clinical trials have helped us to deliver the results that we want to see in order to improve the outcome in CLL. And we are in this phase now, which is what we call as a phase 3 clinical trial, where we are looking at a question, a hypothesis now, where we are trying to look at a question whether continuous therapy versus intermittent therapy is what we should be giving to our patients. And this is a question which has not been answered anywhere in the world. So this is the only trial, static trial is the only trial which is looking at that question of continuous versus intermittent therapy. And I hope that the video explains this quite nicely, and hopefully we are able to ask answer any questions that you may have after listening to the video that Professor Hellman and myself recorded a few weeks back. I must say that this is not an early phase trial, which is different to what we call as a phase 3 trial, and this trial is now showing us that we know that ibrutinib is an effective treatment, and we have data from the FLAIR study, but now we are asking a different question, whether giving continuous ibrutinib or giving it intermittently would be the right approach, and the trial is the only way to answer that question. So I think I will stop at that point and let you watch the video, which is, I think, hopefully should come up very soon. And then after that, I'm very happy to answer any questions that you may have.
Hi, Pete Hellman here from Leeds, Professor of Hematology, and I'm joined by my colleague and friend Tal Munir, who's, and we're going to be talking today about the opening of static, a long-awaited trial that we've been working on for quite a long time. So static is a randomized trial, which we'll talk about in more detail, for patients being treated with ibrutinib. Patients are eligible for static if they are either coming out of the FLAIR trial, which many of you are very familiar with, and I'll talk about a little bit in a moment, or patients who've been on ibrutinib and are well controlled, who had previous treatment and are now going on to ibrutinib. So FLAIR, I'm sure many of you are aware, is really our flagship trial in the UK, which started recruitment in 2014, seems like yesterday, and treated patients with previously untreated CLL who required therapy. The first part of FLAIR compared ibrutinib with rituximab against chemotherapy, FCR, and we demonstrated very clearly in that trial that patients who were randomized to ibrutinib had a longer time until progression. So that was the main endpoint of the trial. We're doing very well compared to those patients treated with FCR, although we know FCR is a good therapy for CLL. And subsequently, we have looked at the combination within FLAIR of ibrutinib plus venetoclax. So the data from FLAIR is positive in terms of ibrutinib containing arms. We're still collecting information on there's some more endpoints for FLAIR, but the first part is now out. When we designed FLAIR actually in 2012, and ibrutinib wasn't actually approved for use anywhere until 2014. So at the time, we weren't really certain about either the long-term safety of ibrutinib. So, and obviously at the moment it's being used mainly until patients progress or don't tolerate the drug. And we were not certain really how long we should use ibrutinib for in FLAIR and what we would do with what we should do later on. And I think we got a lot more information about that coming from FLAIR and other trials. And initially in FLAIR there was a 6-year period of treatment with ibrutinib, and then patients were to stop, although static allows patients to continue on at least active therapy later on. So the information in terms of safety from FLAIR and the emergence of some patients who don't continue to respond is what's driven the design of static. And I was going to hand over to Tal, who presented the safety data from FLAIR and is very aware of the other ibrutinib data from other trials. So Tal.
Yeah, many thanks, Pete. So yeah, I'm Tal Munir. I work with Pete, and Pete is absolutely right that FLAIR is the biggest trial actually in the world, really, who's recruited so many patients, and it's fantastic that we've been able to deliver the trial in a positive manner, and the data is out there in public domain, and also and clearly ibrutinib has been the better drug, but is the better treatment as compared to the FCR in terms of the progression-free survival. But we also were able to look at the long-term effect of ibrutinib, and especially looking at the side effect profile, because one of the problems with the continuous therapy is the accumulation of adverse events over time. And what we found was that we have to carefully monitor our patients' blood pressures and also introduce other things which we were finding in the trial, and that I presented that data at American Society of Hematology meeting last year. It was overall showing that the drug is safe to take, but we need to be careful about this. And this trial has allowed us to actually look at the long-term effectiveness as well as the safety of the molecule as well. And one of the other things which Pete alluded to was the development of resistance. So FLAIR has allowed us to serially monitor our patients and looking at the resistance patterns that develop over time. And this is the concept that we will take forward in static trial. And the main question that we're trying to answer there is whether continuous therapy is the right approach. And if we are going to use a continuous approach, whether the resistance would develop, which can happen with long-term therapies, or the intermittent approach is the right approach to take, whether we will reduce the side effects of the drug as well as reducing the risk of development of resistance. So I think that's all I have to say, Pete, and I'll hand over to you about the concept of the static study and how it was conceived and why it has taken us so long to kind of open the trial.
Thanks, Tal. So static is looking at the intermittent treatment of patients with ibrutinib. So just take a slight step back. In other cancers, prostate cancer, good example, or renal cancer, there's been work looking at these similar types of therapy where if you use intermittent treatment rather than continuous treatment, patients are less likely to become resistant to that therapy, and actually in some cancers like that, the outcome is better for intermittent than it would be for continuous treatment, because it prevents resistance. And obviously also intermittent treatment is less likely to cause side effects because you're stopping the therapy for some duration of the treatment. We also know from both FLAIR, but more in other trials, that patients who are on ibrutinib for a prolonged period of time, and so 2-3 years or longer, are usually in a very deep remission. And so when we look for CLL, there's extremely low levels of CLL present. It very rarely gets rid of it completely, but it's at such a low level that when we stop ibrutinib, it takes often months or many years even, for the disease to actually rear its head and reappear again. So we know that in patients saying at a low level of CLL, there'll be a prolonged period if someone stops treatment, and then before they restart it. And with CLL and other diseases, retreatment at that sort of early progression usually controls the disease again. So there is a rationale which would suggest that intermittent treatment may be, in someone who's in a good remission, may be more effective than giving continuous treatment. Maybe that's partly due to the resistance that Tal mentioned. So in static, we're going to include patients who come out of FLAIR. So just about half the patients will be on ibrutinib in FLAIR, will have been on ibrutinib for 6 years. They'll be in a good remission, because almost all the patients are at that point if they're still on treatment. And then half the patients will be patients who aren't in FLAIR, may not be in a trial at all. They're patients who've had previous treatment, and then in second or third or further lines of therapy will go on to ibrutinib. And those patients have to be on ibrutinib for at least 3 years, and been in a good remission for at least a year to be eligible for static. Obviously, patients need to be well controlled in terms of their CLL if we're going to think about stopping the treatment. Or pausing the treatment, I should say, so not stopping it completely. So those patients, there'll be 800 patients in total, will be randomized, so they'll be selected. Half of them will continue ibrutinib without stopping, and the other half will have a pause in their ibrutinib till stop, and will be followed in the trial every 3 months. So watch very, very closely in terms of a blood count. There won't be any CT scans or bone marrows. It'll be just a clinical follow-up and blood count. And as soon as the CLL starts to reappear, so we see a lymphocyte count of 5, or we see any lymph nodes, which is what we normally see in CLL, the patient will then restart the ibrutinib, and we'll go back on ibrutinib. And if they then go into remission again a year later after being in remission, they can then stop again. So it's intermittent treatment rather than stopping treatment against continuous therapy. And we're going to be looking at which of those two approaches, the intermittent versus the continuous, is most effective, and before a patient has to switch to an alternative therapy. And remember, there are lots of alternative therapies for CLL for most patients. There is a small group of patients that is called a cohort of patients called the patient need cohort. We initially thought we would have a choice cohort that patients could choose to go into treatment, stay on therapy. But the problem with that is we're seeing, as Tal said, side effects. So over time, hypertension is an issue. Over half the patients in some series are having high blood pressure, and irregular heartbeat is an issue, as well as other issues. Nail, I mean, many of you are on ibrutinib may be familiar with the sort of nail issues and some skin issues we see, and other issues with ibrutinib. So we know that continuous therapy can cause an issue, and therefore, and also the resistance that we talked about. So the rationale is that we should really be thinking of intermittent rather than choosing to stay on ibrutinib. The patient need cohort is for patients who, at the end of 6 years, already have a lymphocyte count above 5 or have lymph nodes that we can feel. We therefore wouldn't want to stop those patients, and we wouldn't stop them at 6 years either, so they can choose to go into static and remain on therapy. And we think that will be a small number of patients. So that's the rationale. The other group I should mention is that our patients, because FLAIR started in 2014, so there'll be some patients who stopped ibrutinib between now and 2 years ago, and those patients would also be eligible to go into static and can be randomized in the same way, even if there's been a pause in ibrutinib in the meantime. So for that group of patients, we can still include those patients in static if they would like to do so. So I think it's an important study. It's probably the only one globally that's looking at. I think that I'm aware of looking at such an approach in CLL, which as I said is very rational.
Pete, I just want to emphasize 3 points that actually you made, which I think is very important. One is that we're talking about patients without active disease, which is, you rightly mentioned, lymphocyte count above 5 or palpable lymph nodes. And in those patients, if there is any active disease, then those patients would be going into the patient need cohort. Whereas we will kind of stop therapy in patients where we can't feel any lymph nodes and the lymphocyte count is low. So the active disease is important concept as compared to progressive disease, which is slightly different, which needs IWCLL criteria. But this is the rationale of using the drug early on. And then the second point that you very importantly made is the patients who have already stopped therapy would be eligible to go into static, which is important, and it would be very important to look at the pattern, how the disease evolved from there on. So I think those are the 2 important points, and the third point I think you covered very nicely was about the patient need cohort, and I think that is very important concept that hopefully we will be able to get some more data in the trial.
Yeah, and just for completeness, right, for those listening, we've had actually our committee meetings this week to initiate static, so it's now ready to go. We're opening sites around the country over the next few months. The trial, we have 2 main committees. There's a data safety committee, so there are independent hematologists who are CLL experts from the UK who will follow the data to make sure that patients who are randomized to the intermittent arm are doing okay. And so we watch that very regularly. So, for example, if we find that one group of patients shouldn't be given in that approach, it won't continue through the whole trial. It'll be monitored very regularly by an independent committee. We expect, usually their job is just giving us security, really, and the rationale, I think, is strong. Maybe the patients with very high levels of disease going into randomization shouldn't possibly be stopped, and we'll know that data from starting, and we will modify the trial accordingly. There's also a trial steering committee, which again is oversees the trial, which is independent to Tal, myself, and the team at Leeds. And then finally, CLL is we've got very good treatments for CLL, and the data from FLAIR and other trials shows that the patients now are doing so well that they're living for pretty much normal life, led to life for many patients. There's so many treatments available, and we need to think about the future investigators, because I'm the chief investigator of FLAIR and static, but as many of you know, I'm not getting any younger, and so Tal will be taking over as the if you like, the lead for static. The chief investigator is the jargon in the next year or so. I'll still be involved. I'm still involved in the science behind it and keeping an eye on things. But so that's why the 2 of us are on this call.
Thanks very much, Pete. Yeah, I'm looking forward to taking up the journey that you've started. So yeah, and it's been an honor to be part of that, and would like to continue with the great work. And would like to thank all the patients, all the participants of the FLAIR study, and hopefully we can take it forward to static, which is finally we are able to open it up now.